progressive till to the present day. It was associated with high colored urine, pale colored stools for the past 2 weeks. There was no any associated abdominal pain. Generalized itching from 1 month. It is gradual in onset, predominantly over extremities and back. Grade 3 in severity, that is worsening in night, affecting sleep but not interfering with daily activities. There was also loss of appetite and weight loss of around 7 kgs over 2 to 3 months. There was no history of abdominal distension and awareness of mass per abdomen. There was no history of fever, chills, night sweat, and antral sensorium. There was no history of prodrome prior to the onset of jaundice, and there was no alternate medicine intake prior to the onset of jaundice. There is no history of hematemesis or melena. There is no history of IV drug abuse, tattooing, or blood transfusion. There is no history of skin rashes, easy bruisability, muscle cramps, bone pains, and there is also no history of recent onset of diabetes. Coming to past history, he is a known hypertensive. There is no history of any similar complaints in the past. There is no history of diabetes, thyroid, seizure, or tuberculosis history. Coming to treatment history, there is no any history of surgeries or endoscopy procedures in the past. He is taking only amlodipine 5 mg OD. Apart from that, he is not taking any other medication. Coming to personal history, he is an occasional alcoholic, smoker with smoking history of 20 years. He consumes mixed diet. Appetite was reduced. There is no high-risk behavior history. And family history was not significant. Coming to summary, a 65-year-old male who is an alcoholic and smoker with hypertension presented with an index episode of insidious onset of painless progressive jaundice of 2 months duration associated with pruritus and pale color stools that is suggestive of cholestatic jaundice with significant weight loss in the absence of prodromal symptoms without symptoms of fat soluble deficiency with performance status ECOG status 0. I would like to consider cholestatic jaundice, likely extrahepatic of malignant etiology, but intrahepatic cause could not be ruled out. So my DDs are cholangiocarcinoma, carcinoma head of the pancreas, and ampullary malignancy, and carcinoma gallbladder with CHD infiltration, sir.
Okay, can you just tell us why you put these diagnoses in that order and what are the points in favor or against each of these for you to consider?
For cholangiocarcinoma, as patient is elderly male, and he presented with insidious onset and painless progressive jaundice with weight loss and pruritus and pale color stools. Pale color stools suggest of complete obstruction of bile duct. So I am considering cholangiocarcinoma, sir. First.
No, the point is all those points are in favor of extrahepatic malignancy, but in those differential diagnoses of these four, why is there any particular reason that you rank them in this order? What you just now said applies to all four.
But the carcinoma head of the pancreas, 30 to 40% are painless, no, sir. That's why more painless means cholangiocarcinoma I considered.
Dr. Kiran, sir is just asking, look, we sometimes base sort of diagnosis on the local prevalence of the disease as well. Right?
Yes, sir. Being south, it should be carcinoma head of the pancreas, sir, first.
In general, what is the data shows that what's the most common cause for an extrahepatic cause for cholestatic jaundice?
Of suspected malignant
etiology.
In North India, carcinoma gallbladder, sir. In South India, most common is carcinoma head of the pancreas, sir.
So which literature are you referring to? Like, I mean,
HCPCA.
There is a change in the prevalence of extrahepatic cause for malignant etiology. Previously it was different, now it is little differences there, right?
Okay.
So you think it is carcinoma of pancreas based on the prevalence, or since the patient is an alcoholic, you think it is how do you substantiate your diagnosis? Right? Because cholangiocarcinoma is a little rarer disease, and age of presentation is different. And the second thing is one thing what I want to suggest to all the postgraduates: there's nothing like a occasional alcoholic, right? Patient is an alcoholic or not, that's all. So please don't use the term occasional alcoholic. Alcoholic means it is significant cause. It has some guidelines. Okay. So it's an alcoholic background is there. Now he's he is from South.
Yes, sir. Smoker also, sir.
Yeah. So with this background, so what will be your first diagnosis? You want to
Carcinoma
change
head.
the priority, you want to change the order of the diagnosis.
Yes, sir. Carcinoma head of the pancreas, I would like consider,
Hmm.
but pain was not there.
Pain is only present in 50% of the patients, 40 to 50%. So still the possibility of C-head pancreas is still there,
Okay.
right?
Okay.
So periampullary may first I mean still it is pancreatic head, then the other things come,
Okay.
right?
Okay.
So are there any features that distinguish papillary malignancy clinically? Like, okay, if pain was present and significant pancreatic pain was present, you would, as you said, consider carcinoma of pancreas. So like that, are there clinical features that would distinguish ampullary malignancy from the history?
Sir, as patient had not having any silverish stools and fluctuating jaundice, so I don't consider.
No, it's not don't consider. If
You
they
don't,
are
but,
there, that
they're
will
there.
be in favor. If it's
Favor.
not there, it doesn't make a difference. That's the point.
Okay.
So
Okay.
so still possibility is there.
Yes, sir. Possibility is there, sir, still.
Dr. Kiran, but if I ask you the other way around, CA pancreas, if it were to be CA pancreas, but the patient has no pain, how do you justify the absence of pain? What could be the mechanism that there is no pain?
Sir, if pain is not there, means patient is in early stage of the cancer. Because if pain is involved, means it could be an advanced stage because of cilia plexus involvement. And in carcinoma head of the pancreas, mainly it will present with jaundice followed by pain, sir.
Yeah, that's okay.
Yeah. So what else will come in? Look, your DD has to be, I mean, first you thought extrahepatic, problem of malignity. Still, any other possibilities are there? Why can't it be intrahepatic cholestasis?
Yes, sir, it can be
What are the
intrahepatic
features that suggest? Yes.
intrahepatic cholestasis, but weight loss, loss of appetite are against the feature of intrahepatic cholestasis. And
why should they be?
Any disease can cause weight loss.
but
This kind
prodromal
of-
symptoms are not there, no, sir.
Yeah,
Prodromal symptoms.
okay.
Prodromal symptoms
Prodromal
and
symptoms, why? In what context would prodromal symptoms be significant? Why would the absence of prodromal symptoms rule out intrahepatic cholestasis of unknown water etiology?
viral etiology, sir.
Okay, are there other etiologies of
Yes, sir, drugs.
intrahepatic cholestasis?
Yes, sir, drugs and
Yeah.
infiltrative disorders and
Yeah, exactly. So they might equally follow the same pattern as extrahepatic malignancy.
Yes.
So
Your DDs has to be basically, I mean, divided into extra and intra, and then you have to differentiate. You always have to put some benign causes because still you're not sure sometimes, right?
yes.
What are the extrahepatic benign causes that can cause this? How much ever rare it may be?
So cholelithiasis may cause, sir, about 10% of cases. Elderly males, they will present with painless progressive jaundice, sir.
Cholelithiasis. So what are the instances like? I mean, suppose the patient is already having some anatomical defects there.
Yes, sir.
then the patient-
So as patient are not having any previous history of surgeries or cholecystectomy status, less likely considering benign etiologies.
But
Yeah.
sometimes, what are the other things? So the patient is alcoholic and significant smoker. The patient might be having a chronic pancreatitis with a distal CVD stricture also, right?
Yes, sir.
Which
Distal
is
CVD.
symptomatic sometimes.
Yes, sir. Can be there. Sir.
Always, I think you have to divide your differentials into benign and malignant, extrahepatic and intrahepatic, right?
Yes.
So in this, what are the possibilities?
If
Going
it
back.
were to be benign, what are your differentials?
Differentials.
95% is malignancy, but
Yes.
benign.
Benign causes may be cholelithiasis or recurrent pyogenic cholangitis can be there, sir. And benign biliary strictures in the background of post-cholecystitis, post-liver transplant.
Okay.
Now, in this setting,
In this case. Already I gave you one clue. So just enumerate all the possible benign causes in this patient.
See, you should bring in
Then
lymph.
biliary stricture, chronic pancreatitis related.
Okay, one thing is that. Second thing, you are telling about CBD stricture, stone and stricture. Is it a possible option here?
Yes, sir. Can be.
Sometimes still it can be.
Yes, sir.
What else?
So Kiran, it would be easy if you divide it this way. So okay, malignant. So one other is stricture. You are saying, no? Stricture again, it can be malignant, inflammatory, or so inflammatory. Enumerate the cause. It can be TB. It can be IgG. How much ever rare it may be. IgG4 disease, eosinophilic, and
Sclerosing cholangitis,
HIV cholangiopathy. There are many other things. Where
ischemic. Yes.
ischemic setting, this is not a setting, right?
Chemic is very rare. Huh?
Oh.
In this setting, even if you find a mass and 1 out of 100 will turn out to be IgG4. So it's for discussion, but rare possibilities, you should bring in all those. Lymph nodal compression.
Lymph nodal compression. All these things still you have to keep in mind before you just straight away go into malignancy.
Okay.
Once you see large number of cases, the law of averages catch up, and once in a while you come across these differentials. If you don't have imaging, everything is a possibility. Though I agree, 90% or above it should be cholangiocarcinoma or CA pancreas.
Yes.
So if it were to be intrahepatic, what would be even?
Yeah, I think if we can at least list the intrahepatic causes of progressive cholestasis like this, that will help.
Sir, intrahepatic cholestasis can be divided into hepatocellular, sir, drugs, virals, drugs like OC pills, anabolic steroids, macrolides, antithyroid and anti-epileptic medication. Virals like A, E, B, hepatitis B, hepatitis C, Epstein-Barr virus, cytomegalovirus, and HSV can cause, sir. And some to extent, alcoholic hepatitis can also cause, sir. And inflammatory disorders like TB, sarcoidosis, and lymphoma and amyloidosis can cause, sir. And at the cholangiocyte level, PSC, PBC, and canalicular level, benign recurrent intrahepatic cholestasis, progressive family intrahepatic cholestasis of pregnancy, and sepsis also can cause cholestasis, sir.
No, but it's not the setting, right here.
So you enumerated so many. No? So in this, can you just one or two possibilities out there which can fit in this?
At this age, what is this? At this age, and suppose if the patient is younger, what are these differentials?
If patient is...
You said AE is okay, but if it is EBV and HSV...
I don't think is okay. 65 years old, you won't have acute HIV.
But at least EBV and HSV, why do they go into cholestatic phase? Is it reported?
Yeah.
You can't enumerate all viruses that we know, right?
Okay.
You have to be logical and cut at some point. Then every disease will become a differential.
At this stage, what is the differential intrahepatic and extrahepatic cholestasis? If a patient is younger, what is the differential for intrahepatic and extrahepatic? That type of analysis you have to do.
And drug, you have only amlodipine. Does amlodipine cause this? Bring in drug, or else you don't have the history, you don't have it.
Okay.
And bring in drug, right?
Okay.
Does amlodipine cause this? Just check that. That's all. You shouldn't bring in too many factors.
Okay, sir.
And see, if you don't have a differential, even that is fine.
Okay.
You have to stick to your...
I think we'll go on to the physical examination.
Sir, one point. Kiran, can it be autoimmune pancreatitis?
Yeah, IG4 was mentioned by Prakash.
IgG4,
was
okay.
mentioned.
IgG4 was mentioned. Okay. Okay.
That is a possibility, is there?
Yeah, it's always there until...
Infiltrative diseases, if that was not mentioned, you should. Sarcoidosis.
And still I think lymph node obstruction at the level of distal CBD is a possibility in these patients.
Yes, sir. Can be possible.
So that's also important.
Okay.
So with this background, let us go to the examination briefly. Yeah.
Yes, sir.
Yeah.
On general examination, patient comfortably lying in supine position, moderately built in moderately nourished. BMI was normal, and vital parameters are within normal limits. Scleral icterus was noted. Scratch marks over abdomen and limbs were present. No pallor, pedal edema, clubbing, cyanosis, lymphadenopathy, no xanthomas or xanthelasma, no signs of liver cell failure, no ostrexis, no signs of ecchymosis, petechiae, beta spots, no signs of internal malignancy. JVP was not raised. Oral examination was
Then
normal.
you can do one thing, just enumerate the positive findings. I think that would
Yes, yes.
Yeah.
That's better. That's better.
Sir. Coming to systemic examination, on palpation, GB was palpable, non-tender, smooth surface, soft to firm in consistency, moving with respiration, with side-to-side mobility. Digital rectal examination was normal, and other systemic examination were normal. My final diagnosis: 65 years old male who is alcoholic and smoker with known hypertensive, presented with index episode of insidious onset painless progressive jaundice with pruritus and pale color stools with significant weight loss, with palpable GB in the absence of prodromal symptoms, without signs and symptoms of fat soluble deficiency, with ECOG status 0. I would like to consider extrahepatic distal biliary obstruction of malignant cause, not in cholangitis. My DDs are distal cholangiocarcinoma, periampular malignancy, carcinoma head of the pancreas.
Okay, so after examination, you would still stick to first diagnosis distal cholangio or anything else? I mean, you want to change the priority?
Yes, sir, palpable GB.
No, that's fine. Palpable GB is there. We know that there is an extrahepatic distal obstruction.
Okay.
So you still want to go with a cholangiocarcinoma distally or?
Carcinoma head of the pancreas, I will go, sir.
Yeah, the one first possible. Second possibility is
Second, periampular malignancy, ampular malignancy.
ampullary. Ampullary, there's nothing to suggest. I mean,
Okay.
it doesn't have any anemia as such, right?
Okay.
No, there's no
Next,
period.
distal cholangiocarcinoma, sir. Next.
Next is
You
distal
say
cholangio.
So what is de
periampulary
Courvoisier's law?
Ah.
What is de Courvoisier's law? What does it say?
In a patient with obstructive jaundice, a palpable
patient with
distal,
jaundice. In a patient with jaundice, the gallbladder is palpable. Then what is the inference?
it is not due to stone disease, sir, gallstone disease. Because
It is not due to stone. It is at the obstruction at the lower end, and probably it is malignancy. These are the three inferences from the de Courvoisier's law.
yes.
Is there any situation with gallstone disease where you can have a palpable gallbladder?
Yes, sir. Double impaction of the gallstone, mucocele of the gallbladder, and empyema of the gallbladder.
So they are all.
And
Exceptions to Courvoisier's.
Okay.
So even there are two more exceptions.
Two more,
Suppose if
yes.
you don't have a palpable gallbladder, you have to consider one thing is either a post-cholecystectomy where they can have periampullary, they don't have any this one.
yes, sir.
It is very, very, very low insertion.
Yes.
If the gallbladder is operated, though you don't have any, you won't feel the palpable
Yeah, and the
gallbladder. That is one
second thing is you can rule out CHGB. You thought it is a firm to soft GB. Usually GB will be hard. You cannot move once.
It won't move. Yes.
So it won't now, I think.
Even very, very low insertion of the cystic duct also, you don't have that much palpable
Yes.
gallbladder.
Kiran, why can't it be a Mirizi?
Mirizi is an exception, yes.
Many times we confuse it with cholangiocarcinoma.
Cholangiocarcinoma.
Always keep it.
Okay, sir. Can be, sir. Mirizi.
What will be the clinical presentation if it is Mirizi's?
So Mirizi is one of the exceptions for de Courvoisier's, right? So among the non-malignant causes, what do you want to give? Sir is explaining, no?
Suppose in the same patient, if you don't have palpable gallbladder, what is your differential?
Sir, I would like to
You don't
consider
have
hilar cholangiocarcinoma, sir.
Yes. So that is one thing which will distinguish between hilar from the periampullary. So if you don't have palpable gallbladder, you will think more of hilar cholangio.
Okay.
Kiran, you did not answer that question.
Other extra causes.
Kiran,
Yes, sir.
Kiran, why is it not Mirizi? You did not answer that question. That's very important.
Yes, sir. But in Mirizi, there won't be any weight loss and anorexia.
No. One future will differentiate Mirizi from distal CBD malignant obstruction.
Pain abdomen, sir.
Yes, very
Pain.
good. Pain.
Malignancy is
Maybe it's
effectively
caused
an
by
inflammatory
stone.
condition. You're going to have a lot of pain and tenderness related to the gallbladder. That's not what is causing the obstruction. Okay, shall we go on then?
Yeah.
Then I would like to do routine investigations like CBP. He was mild anemic, platelets were normal, and on a lefty, there is gradually, progressively increasing obstructive pattern of jaundice with bilirubin levels rising from 9.7 to 17.5 with mild transaminitis and significant ALP elevation. And other routine labs, INR was normal limit, within normal limits. RFT and RBS were within normal limits. Viral markers, especially HBsAg and HCV, negative.
The
With this,
LFT, in the LFT, you neglected to mention one important parameter, which is right at the bottom of the chart.
albumin. Sir.
Yeah, so isn't that important?
Yes, sir. Albumin is important.
A low albumin in this setting, what does it tell you?
Synthetic function is affecting
No.
Not just synthetic function being affected.
catabolic state.
Yeah, it is some systemic inflammatory catabolic state is happening.
Why is amylase lipase done?
To rule out chronic pancreatitis.
Don't rule out. No relevance, sir. Don't do.
Okay.
Don't do also.
Okay. Sir.
Yeah, and additionally, low albumin will also matter as far as prognosis and management is concerned.
One is diagnostic as a prognosis. In diagnosis of ampullary malignancy, again, you can have a lot of blood loss, and then there you can have low albumin levels.
Yes.
Okay.
So
With-
what is so?
With this, I would like to do a first ultrasound abdomen, sir, to know the obstruction.
So what is the role of ultrasound in a patient with jaundice?
Sir, to know IHBRD and to trace down the IHBRD till the distal part, sir, and to know ascites and peritoneal deposits or
No.
on the gallbladder.
So first of all, the ultrasound tells you whether there is obstruction or not. The first investigation is ultrasound. It will tell you whether there is obstructive jaundice or not. It will rule out a intrahepatic cholestatic jaundice. Second thing is, it will tell where is the level of obstruction. Suppose if the CBD is dilated till the lower end, you will know the level of the obstruction. To some extent, you will know the etiology of the obstruction. So whenever you're asked a question to tell what is the role of ultrasound in patient with jaundice, you will say that it will confirm the obstructive jaundice. Second, it will tell the level of the obstruction of the jaundice. And third thing is, it will tell to some extent the etiology of the jaundice.
So my
So
question
these are the three
is,
things you should do.
and my question is, in what settings of with biliary obstruction will the ultrasound not show intrahepatic biliary radical dilatation? Patient has biliary obstruction, but in what settings the ultrasound may not show IHBR dilatation? Simple.
Early phases.
Obstruction, number one. Second,
intermittent
intermittent obstruction, number two. Number three,
Any
Intrahepatic.
condition?
Intrahepatic,
not
Intrahepatic.
chronic inflammatory.
reduced compliance of the liver. The patient already has chronic liver
Cirrhosis,
disease or
liver
something
disease.
else, and may not be able to pick up the biliary obstruction. So these three you have to remember as for the possibilities where IHBR may not be seen on an ultrasound. Okay, next.
In this patient, there is no anemia and counts are normal. So, is it interesting that like you are suspecting a malignancy, 2 months duration? There is no anemia, hemoglobin is normal,
I'll say even INR is normal.
INR is normal. I think it's quite interesting.
While the albumin is low, that's a
Yeah,
little odd combination.
Yes. Yeah, albumin is also normal.
Kiran,
So-
what if this patient has pain and fever now? 2 months ho gaya.
Okay.
How still he has pain and fever? What are the differences? Same presentation, has pain and fever. He's alcoholic also.
So there is a possibility of cholangitis, sir.
Yeah, does your differentials change?
Sir?
Do your differentials change?
Yes, sir. With intervention, he will develop cholangitis, sir. Without intervention, it will be sterile.
Not intervention. Till now,
Okay, sir.
we know the labs, we don't know the ultrasound yet.
Okay, sir.
Same history, 2 months weight loss, whatever. He has pain and fever also.
Any GB perforation, sir?
No,
CAGB with
Same history that you have elicited.
same history. Look,
Oh, same.
Painless, he has pain, he has intermittent fever also. The same history, no change. 2 months, 7 kg weight loss, everything.
Any change in the order of your DD?
Sir?
You answered all this, but structure it again. The same presentation, patient
Okay.
has pain and fever also. You are emphasizing no painless. That's I put malignancy.
Pain and fever means, pain means I would like to consider CAHOP and CAGB, sir.
Yeah. Now, if pain is there, your stone disease, Mirizi, all these will come
Come into the picture more actively.
Okay.
more forefront. But still, see, even ampullary can have pain. It's not that nothing is going to. These are like, how do you position your differentials?
Okay.
Okay,
Kiran,
let's go on.
for example, if the sugar is around 300 for the first time you have noted now,
Okay.
how do you interpret that?
Elderly male with first new onset of diabetes, I would like to consider pancreatic malignancy, sir. I will rule out.
how does CA pancreas cause diabetes?
Sir, it will cause diabetogenic factors like production of adenomedullin and destruction of islet cell beta cells, sir. And
Oh, yeah.
cytokine mediated insulin resistance.
Okay.
This factor you should consider in a
half
patient
another.
you are falling with chronic pancreatitis. If they're present with weight loss and uncontrolled diabetes, then you should think of pancreatic malignancy. Any persistent pain, weight loss, uncontrolled diabetes in a patient you are following with chronic pancreatitis, probably that will make you think of that carcinoma pancreas.
Yes.
These are tried.
Okay, imaging.
Okay.
Okay. that is
On
true.
ultrasound, liver was 12.8 centimeters. Moderate HBRD was noted. Gallbladder over-distended with sludge. CBD 14 mm. No ascites. Impression dilated CBD with moderate HBRD. CA19-9 was 146 units per ml. And MRI and MRCP on a mild HBRD noted. CBD 13 mm. There is abrupt smooth narrowing is seen at the ampullary region associated with mild moral soft thickening of the CBD measuring approximately 3 mm in thickness, extending for a length of 7 mm.
And
And,
stop here. Once you do ultrasound, what is the next investigation you will choose?
Yeah, that is the question. When you do an ultrasound, then what is the next? Is it MRI or a CT, contrast enhanced CT?
Sir,
Which is the investigation of choice?
Sir, depending on obstruction, if it is a higher obstruction,
Yeah.
I would first go with MRCP, sir. With the distal, I will first choose CECT, sir. CECT pancreatic protocol.
So what is pancreatic protocol?
So in this, there are 3 phases, sir. Arterial phase and pancreatic phase and a delayed phase. Arterial phase will be there for 25 seconds. In arterial phase, arteries will be enhanced. In pancreatic phase, it is for 40 seconds. Any enhancing lesion will pick up, sir. Usually CAHOP, hypo enhancing lesion, sir. In delayed venous phase, vascular venous involvement is picked up, sir.
So typical pancreatic protocol is 50 to 70 seconds after giving contrast.
Okay, sir.
Usually 57.
And if you think of a neuroendocrine tumor, it is a very early arterial phase, very
Yes, sir.
important.
Yes.
It's more
Hyperenhanced.
vascular.
More vascular. So with this thing,
So your choice of investigation now in this patient, is it CT or MRI? And what does MRI will give additional advantage over ultrasound? Because you will know the dilatation,
Yes, sir.
biliary dilatation anyway in the ultrasound. You
Yes.
will know the level of obstruction in ultrasound to some extent. How does it will be advantageous to have an MRI abdomen in this
Rather than
case?
CT scan.
Sir,
Rather than CT
in
scan.
MRI, better biliary anatomy can be seen, sir. With and MRI tells about functional liver volume.
Now CT will also tell.
I think,
It will
yeah,
all tell.
I'll tell if there is no clinically an ultrasound is not clear in terms of the obstruction, but you're suspecting obstruction, that is where the MRI comes and MRCP coming to the picture, where there is a strong suspicion of obstruction, but you're not. In a case like this, I would also say CECT is the investigation of choice. I don't know whether others would agree, but
In general, it is CECT abdomen
you'll
because
get all the information that you
Yeah.
need from a CECT.
Yes,
It is much more
especially-
easily available, easily doable, apart from,
And you will see the lymph nodes, you will
lymph
can
nodes,
stage
local
the patient,
metastasis,
vascular
staging of the
involvement,
disease.
everything you can do.
yeah.
So it's
MRI is that situation where you want to evaluate the bile duct, which you think might be obstructed, might not be. You want to get a better information, then you go MRI first. Right, carry on.
In this situation,
What are your differential? Have you got the CT
Dr.
information?
Srinivas, you
Ah,
asked-
You got
sir.
CT
Yes,
information
sir.
also? Okay, show us that.
So in this situation, probably there is a complementary, sir. We should probably go for both CT and MRI in this situation. Well, CT may be better for picking up a small tumor or anything. At same time, MRI is better for some soft tissue delineations. So especially if you're thinking of a benign condition in this case, like there is a small stone or something, or if you are thinking of IgG4 condition, then probably that wall thickness and persistence, even in IgG4, even with the very significant stenosis, usually we can make out the persistence of the lumen, which is not usually seen in malignancies.
No, we were just discussing which comes first. I mean,
Yeah,
basically,
so that
broadly, I would
sometimes
say
it is not
CT
like
first and then
we may have to do both for complementing each
that's
other.
fine. That's fine. So you've already done endoscopy and CT scan.
Sir, on endoscopy, there was friable ulceroproliferative growth noted at ampulla, sir. So to rule out, for staging, I have done CECT abdomen, sir. Gallbladder distended, CBD 1.3 centimeters, dilated with IHPRD. MPD was also dilated. There was ill-defined heterogeneously enhancing soft lesion noted involving periampular region at the second part of the duodenum with few peripherally enhancing lymph node, peripancreatic lymph nodes. Portal vein and SMV were normal, sir. So they have given double dilated CBD and MPDs.
Kiran, based on the imaging that you provided,
Okay.
it seems that this patient had the luxury to get both MRI and CT done.
Okay.
Okay. Suppose you have both MRI and CT, then okay, the MRCP didn't even give the resectability status because it's a non-con. Suppose
Yes.
you do a contrast MRI, you have both at the same price or free, whatever. What are the difficulties that a radiologist will have because you are ordering an MR? What are the difficulties a radiologist can have? The information that they can't provide to you in an MR. You should know this because you are ordering this test. Why a CT over MR?
Vascular invasion.
Contrast MR. Contrast MR versus contrast CT. What is the problem? Why we choose contrast CT over a contrast MR? Because MR gives more information. Still, we use contrast CT. Why? Say you have 3 Tesla and 256 slice CT.
Don't know, sir.
MR patient has to hold his breath, claustrophobia. There are many factors. The time is long. MR can never give the same quality image if in the same time actually, and you can't. The field of interest in MR will be very low. It's a very focused scan. So it will give at most the characters in a better way for the local site only. And that too, patient should be very cooperative. CT will discount all these factors.
Okay.
You will get a broad view on CT because you will know the bowels, you will know the invasion, you will know the adjacent structure involvement
Metastasis, lung
better in the
involvement.
CT.
And despite a 1 hour study, patient isn't holding the breath properly, or MR is useless.
Useless. Okay.
Okay.
So what
What
next?
will you do once you know this imaging? You want to do an upper GI or you want to do a side view endoscope?
I already done endoscopy.
Upper GI.
So actually better is side view scope.
Side viewing, exactly. Once you know they are looking at the ampulla, better to go for side viewing and take a biopsy.
Yes, sir. Biopsy has taken, sir. And Biopsy report shows submucosa shows neoplastic epithelial cells with round to oval hyperchromatic nuclei and pleomorphic nuclei arranged in glandular and cryptiform bundles separated by stroma, suggestive of well-differentiated adenocarcinomas. They have given.
So what is the final diagnosis, and how do you stage and how do you manage?
Kiran,
Sir.
Kiran,
Sir.
yeah, does US has any role in this case?
Yes, sir.
So was US done, or I mean, if at all, like you have US, then what additional information you will get on US? Will you do US or not?
That is the question. Will
Can
you do
we-
yes or not?
Yes, sir. Can do, sir. To know whether
Can do the, will you do, is it required?
No. Yes or no? You want to do yes or not? That is the question.
for this case, no need, I think, sir.
Yeah.
Don't
There's
require.
no need.
Because you have established the diagnosis, so there is no need, because you are seeing a mass on the endoscope itself, no?
Local lymph nodes are there.
So what is the role of US in a obstructive jaundice? That is the question.
Small
Suppose
leak.
if you don't see the friable growth, suppose you think lower end obstruction, then you will have then you can go for a US and take a FNAC or while doing brush cytology, that latter.
Yes.
So most likely, if it is a lower end distal obstruction, you don't see the growth on either side view or papilla is normal, then you can go for US and take FNAC or FNAB.
Yes.
So the role is in the distal obstruction, where you don't see the growth on the side view or upper GA.
So how do you manage this patient, Kiran?
Sir, first, we'll decide patient whether he is resectable or unresectable, sir.
Yeah.
To decide that, I know distant metastasis status. So CT chest was normal, and there was no any ascites or peritoneal deposits, and the liver was normal.
Any role for PET CT?
No, in this case, no role, sir.
Okay. In this case, do you want to go for a ERCP stenting followed by surgery or straight away surgery?
According to with this history, the patient most probably resectable malignancy, sir. Resectable periampular malignancy. I don't prefer stenting, sir. If patient having any cholangitis or severe pruritus, or if surgery is delayed, or when planning for neoadjuvant therapy, I would like to consider or bilirubin more than 14.5, I would like to consider stenting, sir. In this case.
Get the bilirubin
Plastic or metal stent?
Sir, plastic stent, sir.
Plastic or
Plastic stent.
plastic stent? Okay.
What is the status of lymph nodes in this patient?
So peripancreatic lymph nodes involvement is
Very
there.
small lymph nodes.
Small lymph nodes.
Small lymph nodes, sir.
Do you want to chase them before
Sir?
surgery? Do you want to chase the histology of the lymph node before surgical decision?
No, sir, they are regional lymph nodes, no, sir. So resection can be done.
Okay.
Kiran, tell me this. Here,
You didn't, in this report, you did not mention about SMA status. Superior mesenteric artery.
Not involved, sir.
Okay.
Actually, I heard.
Okay.
Kiran, here there is double duct sign, right?
Yes.
But why did the patient present with liver insufficiency rather than pancreatic insufficiency? Why do patients never present with pancreatic insufficiency?
Sir, to develop pancreatic insufficiency, no more than 90% of the pancreatic parenchyma should be damaged.
Why is
Should
it-
be involved.
Why is it not getting damaged? She's blocked, right?
Yes, sir.
So one reason would be minor PD will be there, no? Some
Okay.
low will be there also.
Okay.
Suppose if this patient develops hepatic metastasis, what will be your marriage? Suppose our local invasion or some multiple metastasis, what will you do? Do you prefer a ERCP and metal stent, or you do go for a surgical, some sort of palliative surgery?
No, sir. ERCP metal stents, sir,
Okay.
for palliation and biliary drainage purpose.
For palliation of the pruritus,
Pruritus.
not palliation of the jaundice. Remember that.
Okay.
Yeah, I think we can go on to
I
the
think-
next case. Anybody has anything specific? We'll
Yeah,
we have two more endoscopic. I mean, two more topics to discuss.
Yes,
Will we
yes.
go on, Filipati?
Yes,
Yeah,
sir,
I
please.
think, Dr. Kiran, thank you for the presentation.
Thank you, sir.
That's a nice one. So I think we can move to the next topic, that is endoscopic presentation by Dr. Arun. Arun, are you ready?
Yeah. So,
I think now
just allow me to
Thank you, sir.
share my screen.
yeah.
Uh, okay. Okay. So, are my slides visible?
Yes, yes.
Yes.
Yeah.
Okay. So, good evening, all. So, I'll be presenting a case for the next 10 or 15 minutes. So this will be a case of pancreatitis with complex pancreatic collection that extends beyond the abdomen. So we have a case with collections in the abdomen and as well as in the thoracic cavity. So I wouldn't say that this is a rare case, but this is how we manage this case. And then end of the case presentation, I shall also, give you an approach to manage these kind of cases, and inputs are all welcome at the end of the presentation. So yeah, so this is a 19-year-old female presented with dysphagia and postprandial vomiting for 1 week, high-grade fever for 1 week, and she had been having pancreatic type of abdominal pain for the past 3 years. So her BMI was 17. On abdominal examination, there was tenderness in epigastric region. She had mild anemia. RFT and LFT were normal. Serum amylase at presentation was 89. Ultrasound abdomen showed features of chronic calcific pancreatitis, and there was a collection in the lesser sac that measured 6 into 6 centimeters. CCT abdomen was also done. It showed chronic calcific pancreatitis. So there was a large pancreatic head intrarectal calculus of around 9 mm. MPD was dilated around 14 mm. There was a large collection in the body of pancreas that was communicating with the main pancreatic duct. So this collection was around 6 into 5 centimeter. And another collection was found in the posterior mediastinum. That was a larger collection. It measured around 11 into 7 centimeter. It was surprising to see that there was no obvious communication between the two collections. So let me run through the CT. So this is the axial CT that shows a large. Can you see? There is a large collection in the posterior mediastinum. Anteriorly, it is abutting the posterior surface of the heart. And posteriorly, you can see the descending aorta and the esophagus that is being compressed. And as you come down into the abdomen, so you can also see another collection here that's in the lesser sac. And as you come down further, so this collection is communicating with the main pancreatic duct. The main pancreatic duct is dilated, and you can also see here a large radiodense intraductal calculus. So this patient has chronic calcific pancreatitis, and I will show you in the coronal view as well. So this is a large collection in the posterior mediastinum, and this is another collection in the lesser sac. So here we have a case of chronic calcium pancreatitis with two collections. And what additional information we need is the content of the collection. So an endoscopy was done. So that showed a smooth bulge over the posterior wall of the esophagus. The G junction was being compressed by this mediastinal collection. There was some mild resistance while passing across the G junction, and you can also see the mucosa around the G junction is edematous and swollen. So this was a collection that was compressing the G junction and resulting in mild narrowing to the passage of the scope. So let me also show the endoscopic ultrasound findings. So endoscopic ultrasound was basically done to see the content of the collection and as well as the accessibility of the collection for drainage. So this is the, so let me slow this down. So this is the abdominal or lesser sac collection. So you could see here, let me stop here. So you could see here, this is a collection in the lesser sac. The content is quite clear. The wall is well formed, and you can also see a small extension here. This extension is into the subdiaphragmatic space. And you can see the diaphragm and the lung here, the left lung. And as the scope is being pulled back, you can also, this is the aorta, and adjacent to the aorta, you have a large collection in the posterior mediastinum. And if you look at the content of this collection in the mediastinum, it's echogenic. So it means that it is turbid. It's filled with purulent material. And you can also see here a lot of septations within the collection. So again, I would like to, I would just stop here and show you some findings on the endoscopic ultrasound. So here you can see here the esophageal wall is clearly made out. You can see all the 5 layers of the esophageal wall clearly made out, including the mediastinal adventitia. So it was extramural, it was not within the esophageal wall. And the most important information that you need to get from endoscopic ultrasound when you are contemplating a drainage is this, whether these collections are communicating with each other or not. So after detailed examination, so we came to know that there was no communication between these collections. So there was a clear delineation between these two collections. So in summary, so this is a case of chronic calcific pancreatitis with 2 collections. So there is no communication between collections or either on CT or US. The lesser sac collection, the content was clear. So you can label this as a pseudocyst, but when you look at the collection in the posterior mediastinum, it was filled with echogenic turbid material with septations. And here, some of the DDs that come into our mind is walled-off necrosis or infected pseudocyst or infected esophageal duplication cyst. But duplication cyst is less likely in the context of this case for a patient presenting to us with an acute history and at the background of chronic calcific pancreatitis. So the decision was made to drain these collections separately. If you look at most of the algorithms or like the treatment algorithms that have been described in literature, the ERCP and PD stenting will come in some point in your algorithm. But in this case specifically, this option was not considered because of various reasons. So the reasons include the patient had a large intraductal calculus. So there is very high chance of failure to cannulate the PD without ESWL because you have a large calculus sitting right in the head within the duct. So this will also not address your mediastinal collection, and there is also a high risk of pseudocyst getting infected if you do an incomplete job. So how do you drain this collection? So we have 2 collections, one in the lesser sac and other one in the mediastinum. The lesser sac, the ideal drainage would be EUS guided. If you're going to do an EUS guided drainage, whether you need to decide whether you're going to place a plastic or a metal stent. So in this case, I would go for a plastic stent or a double pigtail plastic stent because you know the cyst content is clear, it's a pseudocyst, and this patient will need a long-term indwelling stent because if you place a metal stent and remove it after 1 month, then the collection is going to recur, but because there is a downstream obstruction to the main pancreatic duct. And what about draining the mediastinal collection? Will you go by US guided? I would say no, because you need to place plastic stents if you're going by US guided drainage, but it's often associated with high risk of complications such as mediastinitis. You know, the content is very thick and it's going to do an incomplete job for you, resulting in more complications rather than relief. So the best way to tackle this collection would be wax guided, and that would be a safer option. And the next decision that you need to take is what is the order of drainage, whether you would first drain the lesser sac collection and then wait to see whether the mediastinal collection resolves and then drain the mediastinal collection. But the problem in this case was because of the narrowing at the G junction, the scope position, the US scope position was very unstable because of the compression by the mediastinal collection. So this option was not viable. So we went ahead with mediastinal collection first, followed by lesser sac collection next. So this is a video of video assisted thoracoscopic surgery VATS. So so this was done by our thoracic surgeon, Dr. Sriram at GSL Medical College. So here, the first step was identification of the cyst wall. This cyst wall was very tightly adherent to the posterior pericardium. So it was not possible to, completely excise the cyst and remove. So rather what we did was we did a de-roofing procedure. So this cyst wall was open. You could see this thick brownish kind of fluid that's coming out of the cyst. So the entire cyst was aspirated. The cyst wall was partially excised. It was removed, and then the inner surface of the cyst wall was then cauterized, and it was then left open, and finally an intercostal drain was placed. So this was about the VATS procedure that we did first for this patient to drain the mediastinal collection. The fluid that was aspirated from the mediastinal collection had high MLAs. The MLAs was 1100 and the culture was sterile. So next step that we adopted was US guided drainage that was done around 1 week after the VATS procedure. So this was the lesser sac collection. The wall was well formed. It was around 3 mm, as you see that we measured. The scope positioning of the scope, it was also very difficult. As I told you, there was some narrowing, and it was right at the G junction. So care was needed to puncture the stomach right at the cardia, not across the esophagus. So I would like to just show you the steps that we followed. The cyst was punctured with a 19G needle, and O2-5 guide wire was then passed. The cyst was then dilated using a 6 French cystotome. And then the fishless tract was, so this is the, this is the 6 French cystotome, and the cyst wall was then dilated using a balloon. Before that, using a 10 French dilator, another guide wire was placed. So we placed 2 guide wires before doing a balloon dilatation. This was a Titan balloon that we dilated with 10 mm. And finally, we placed 2 double pigtail stents, 7 French and 5 centimeter length. So you can see the positioning of the scope was very difficult. It was right at the G junction, just below the Z line. So this was the scope position. So this was a challenge in this case. So we had to do it very close to the Z line. So finally, we were able to place 2 stents, and you could see post-procedure the cyst cavity, the collapse. This is a final fluoro image that shows 2 plastic stents in situ. So this was the CT that was done 1 week later. So you could see the intercostal tube in situ. There was some basal consolidation post-procedure, and this is the cystogastrostomy stents. So that's passed from the stomach into the lesser sac collection. You could see lesser sac collection is almost gone. And follow up the patient, symptoms subsided. She started tolerating oral diet. There was fever because of left-sided basal consolidation that was managed conservatively, and ICD was removed 1 week after the US drainage. And this was the follow-up CT that was done 1 month after the procedure. You could see here the lung has expanded well. There was a very small residual collection that was asymptomatic, and you could see the cystogastrostomy stents beautifully sitting between the posterior wall of stomach and the lesser sac. The collection is almost gone, and there is some mild dilatation of MPD that you can see with intraductal calculi. So if you look at the literature, how do you manage this pancreatic pleural and pancreatic mediastinal fistula? So there are no society issued guidelines that exist at present for these rare conditions, but most of the evidence that we get from are from case reports and case series. But what evidence says endoscopic therapy should be the first line of management. So there are some recent reviews and meta-analysis that have shown that endoscopic treatment is successful in almost 90% of cases. There are some surgical series that say that surgery is successful in almost 90 to 100% of cases, but I seriously doubt, because these are all biased and most of these would have come from a surgical background. So I would end my presentation here, putting forth an algorithm. How do you manage these cases of pancreatic pleural on pancreatic mediastinal fistula? So first and foremost, if you have a case of acute pancreatitis, you can always try conservative management. You put in an NJ, feed them, maybe give octreotide. So, but if you look at literature, the resolution rate is almost, up to 30%. They can resolve, especially if you have a patient with acute pancreatitis. But if the patient has chronic pancreatitis, then it is unlikely to resolve without an intervention. Always remember, the first step would be to drain the pleural or mediastinal collection, either by inserting an intercostal drain or a VATS guided procedure. So always drain the pleural cavity or drain the thoracic cavity first before embarking on any endoscopic intervention. You can attempt ERCP with the PD stenting, provided there are no large calcifications in the head region. If you look at success rate, if you look at the literature, if you on ERCP, if you find the duct disruption, if you're able to bridge the disruption, the success rate would be around 90 to 92%. But if you are not able to bridge the disruption but place the stent up to the leak, then your success rate would be around 40 to 50%. But if you are not able to reach the level of leak, but at least place the stent across the papilla, then your success rate might be as high as 30%. So all these should be considered when you're treating these kind of patients. But in case ERCP fails, and if you're not able to put in a PD stent, then you go for US guided approaches. The first approach would be an US guided fistulogastrostomy. So when do you do this fistulogastrostomy? Is that you drain the thoracic cavity collection, and you find that the pancreatic collection in the abdomen has completely collapsed, but you find a small fistula tract that communicates between the abdominal and as well as the thoracic cavity. Then you find the fistula tract, and then you puncture the fistula from the stomach, and then you do a fistulogastrostomy. But if you have an accessible persistent pancreatic collection, as in this case, then you could go ahead and do a cystogastrostomy, preferably using plastic stents, because these patients would need a long-term indwelling stents. So thank you very much. So I'm ending this presentation here, and if there are any questions, I am happy to take up.
Dr. Arun, hello. What about doing something like, because there is a large stone, one thing is considered is the ESWL for that large stone, that is also part of the treatment. And the second thing is there any, like you have done with VATS, can you do with because this is a mediastinal collection, it's approachable where you can place US plus plastic stent?
So first thing is ESWL is not widely available, sir.
Yeah, that is true. That's okay. That's why I'm telling you, that's as a part of
we can always,
there is that you can break it, and that's one thing.
So
you
if
can-
you have ESWL, then it's a luxury for you. But if you don't
Yeah.
have ESWL, then we have to think of other modalities. The second thing is US guided mediastinal fluid drainage. Yes, sir. Again, I had mentioned this in my presentation. The problem is like the collection was so thick and infected with lot of septations. So even if we place plastic stents, the chance of the fluid leaking into the mediastin is very high, because you know that it has, it's not a covered metal stent. And plastic stents, they get blocked, and this would add up more to your misery, that, it will cause more of mediastinitis, abscess, and all those things. So we had a discussion with our thoracic surgeon, and then we thought that, okay, we go ahead with VATS first. And again, as I told you, that we also considered first draining the abdominal collection, and then wait, if the mediastinal collection doesn't resolve, then to go for a surgery. But as I told you, there was compression over the G junction, and the positioning of the US scope was very difficult at the level of G junction. So that was the decision that we took. First thoracic, followed by abdominal.
Dr. Arun,
Any comment from?
this
Srinivas?
one. You told preferably you drain the collections in the thoracic cavity at mediastinum before doing a fistula, gastrofistulotomy. But in our experience, what we have seen is once you drain that tract tends to collapse, becomes more difficult to actually access the fistulous tract. So the last few times what I have done, I have just placed the tract, this one first. Then it will make your this one little more easier, procedure little more easier. And many a times that itself will reduce the effusion also, or the collection. If it doesn't, then the next step will we're doing the other way around.
Sir, yes, sir, I totally agree with you, sir. So that was our plan initially, but the problem was that the scope position was very unstable, and we were not able to hold on the scope at that.
No. In your case, it was very difficult because as such, doing it near the G junction is difficult, and that too with the mediastinal connection is this one. But
That
in your
actually
algorithm,
pushing
what
the
you told,
scope further, and probably scope might not be stable actually. At the point.
Yeah.
in your algorithm, you told just drain the first. You told first drain the
Yes,
chest
yes.
one.
Yes.
That one probable variation is probably try this putting in the fistula first, and then that would be a better option.
Yes, sir. Maybe you need to do it in tandem. Within 24 hours, so that
yeah.
when you do a
If you have to
procedure,
do
and
it,
then
yeah, it will be.
you don't have a thoracic surgeon backup, and then patient lands up in an infected or empyema, or whatever infective complication.
Dr. Arun,
Ganpati?
I'm sure you agree that the management of this patient doesn't stop here, because it's a long-term thing, and suspecting that there is a small residual mediastinal and it should come from somewhere. First point is, did you consider a pre-procedure MRI, which could have delineated the tracts or fistulas much better than a CT?
Because the US gave us the same information, sir.
True, but because it was so compressed, sometimes the US scope may jump back, right? So this finer details may be missed on US. So still, I would feel like since it is a mediastinal thing, we expect a tail communication probably. And since it's a long-term disease, probably still doing an MR now and delineating such kind of thing would prevent future recurrences. And I think transpapillary PD stent may be considered in future with or without ESWL.
Definitely, like that's what I was just about to ask, because we had similar cases in the last few months. MRI, I think, is still an option before we plan this procedure. Sometimes it will give us the good route. We had some experience, in the similar cases, we just did an ERCP. They had two collections in the abdomen as well as mediastinum. We just put ERCP PD stent. Sometimes it helps. So I think MRI also should be planned in this patient. But definitely taking the case up and then doing the procedure in a very difficult maneuver is applaudable.
Thank you, sir.
Good case.
Yeah.
So
Any other
before planning
comments?
for
Any other
VATS,
comments?
hi sir.
Sir,
Yeah,
before
Narendra.
planning for VATS, any thoracic like mediastinum aspiration would have changed the management, sir?
No. So we did not think of that because we could always do an US guided aspiration of the fluid and then send it for analysis, but that will not change our management. So ultimately, you need to drain that collection. So I mean, was that the question that you wanted to ask, Narendra?
Yes.
Pre-procedure aspiration. Yeah, aspiration should have been US guided. We can't do percutaneously, US guided aspiration, but ultimately, like whatever the fluid turns out to be, you need to drain that collection, because without draining that, we can't go ahead.
Chalpati, if it is
Yeah.
done, I think we'll go over the last presentation.
We'll go for last presentation. Good case, Dr. Arun. Very well delineated
Good.
multidisciplinary management.
Nicely managed.
Very complex.
Yes,
Thank you, sir.
Thank
Thank
you.
you.
Next is a guideline review quickly for the practitioner's point of view. Dr. Chaitanya.
Good evening, sir. Good evening, respected teachers and seniors and my colleagues. Am I audible, sir?
yeah.
Yes.
So screen share, can we?
You are seeing? The presentation is not.
It's coming, sir?
No, presentation is not there.
Is not coming.
No.
Can the technical team give the screen
Screen
sharing
share.
rights to Dr. Chaitanya? Technical team is there? Pawan?
Screen not visible, sir.
It's not coming
Do you
here.
have screen share options?
Yes,
Are you
yes,
able to
sir.
see
I'll
that?
do it.
Yeah, coming.
So good evening, respected teachers, seniors, and colleagues. Today I'm going to discuss about guidelines on enteral tubes. So initially in 2021, ESG published
Yeah.
guidelines. Later in 2025.
Dr. Chaitanya, make it full screen, please.
Sure, sir. Yes. Is it
Yeah.
visible, sir? Yeah.
Yeah, that's fine. Please go ahead.
So initially we will discuss about ESG guidelines. So indications for enteral tubes. So impossible oral intake due to neurological conditions like post-stroke or ALS or Parkinson's, and obstructive causes like head and neck cancers and esophageal cancers, and catabolic states where need of the patient is more. With oral intake, it is not possible. There we can use enteral feeding. And malignant bowel obstruction, where we have to decompress, there we can use it in like colonic cancer or in patients with pseudo obstruction or severe gastroparesis. It is used as decompressive option. It's a strong recommendation. For every patient, we should follow multidisciplinary team approach. A speech and language therapist input should be there, and we should have a pre-procedural checklist with coagulation parameters, medications, comorbidities, and allergies. And we have to explain the rationale and quality of life and overall prognosis to the patient. It's a strong recommendation with low quality of evidence. Coming to duration, if the enteral feeding is required for more than 4 weeks, then only we should go ahead with percutaneous access, either PEG or DPEG. If it is more than 4 weeks, less than 4 weeks, we should go for simple nasogastric or nasojejunal feeds. Coming to gastric versus jejunal axis, gastric is the standard route. It is more physiological, easier to place. It requires less specialized expertise. Whereas jejunal is selective, wherein altered anatomy or the patient is having severe gastroparesis or intolerance, we should select jejunal route. We can do either direct percutaneous jejunostomy or DPEG, where jejunal in PEG-J, where the PEG inside the PEG we will put a jejunal extension, and DPEG we will directly puncture the jejunum and do a DPEG. Coming to contraindications for nasogastric and nasojejunal tubes, these are related contraindications. Where patients have unhealed facial or skull-based fractures, or recent oronasal or high cervical surgeries, and skull fractures with CSF leakage and severe upper digestive tract obstruction. So in these cases, it is a strong recommendation with low quality of evidence. It is a relative contraindication. Coming to relative contraindications for PEG tubes, any patient with recent GI bleeding due to peptic ulcer or any other reason with high risk of bleeding, and patients on who are hemodynamically unstable and respiratory instability, in these patients, it is a relative contraindication. It is also a weak recommendation with low quality of evidence. Coming to absolute contraindications, where we should not put a tube in the patients with mechanical obstruction distal to the intended site, patients with active peritonitis, and patients with ongoing bowel ischemia and uncorrectable coagulopathy. All these are strong recommendations with low quality of evidence. Coming to antithrombotic management, in nasogastric and nasogeneral tubes, it is a low-risk procedure. We can continue clopidogrel and aspirin. Warfarin also can be continued. We should keep the INR in the therapeutic range. And oral direct-acting oral anticoagulants also can continue. Whereas in percutaneous route, it is high risk, where clopidogrel should be stopped 5 days before, and warfarin and anticoagulants should stop, and INR should be less than 1.5. Coming to other rare scenarios like ascites and VP shunts, in ascites patients, there is impaired maturation of the tract. So there is risk of peritonitis. So we should be very careful in doing PEG tube placement in these patients. In VP shunt, there is risk of infection and malfunction. So PEG should be placed preferably after VP shunts to reduce the colonization risk. So it is a weak recommendation with low quality of evidence. Coming to dementia patients, we should refrain from placing a PEG in patients with dementia because it should not improve the survival and our physical functionality in this subgroup. We should focus on hand feeding and supportive care in patients with severe advanced dementia. Coming to patients with less than 30 days of life expectancy, we should avoid putting a PEG tube because the procedural complications and patient discomfort will be more in these cases. In ALS cases, early placement strategy should be followed when the patient weight loss is minimal and there is good respiratory function, where the FVC will be more than 50%. In that case, if you put a PEG tube, the survival benefits will be there and nutrition status will be maintained. It's a strong recommendation with low quality of evidence. So early PEG placement is recommended in ALS patients. Coming to head and neck cancers, in patients with head and neck cancer who are undergoing chemoradiation, we should plan for PEG placement if patient is having dysphagia, reduced oral intake, or significant weight loss. So it's a strong recommendation with low quality of evidence. Some cases we should place prophylactic PEG in head and neck cancers, where the patient will have pre-treatment weight loss or they are having advanced age, and patient is having naso or hypopharyngeal tumor site, and high and bilateral radiation dosage is required. This is a weak recommendation where prophylactic PEG tube can be placed in these patients. Coming to push technique versus pull technique head and neck cancers, ESG suggests push technique should be followed, not the pull technique, because of the risk of tumor seeding at the stomal tract. But it is very rare. It is 0.5%, but it is serious. Coming to the technique, antibiotic prophylaxis should be followed. 30 minutes before the procedure, we should give a single dose of beta-lactam antibiotic to decrease the post-procedural wound infection. It's a strong recommendation with moderate quality of evidence. Coming to starting time, early feeding should be started within 3 to 4 hours because the delaying feeding time cannot improve the survival or it does not improve any mortality risk. So early feeding is recommended in these patients. It will reduce the hospital stay also. So within 3 to 4 hours, we can start feeding. So it is a strong recommendation with high quality of evidence. Coming to NGT position confirmation, we should not only auscultate, we should check for radiography or pH testing of the aspirate or EtCO2 to confirm the position of the tube. In buried bumper syndrome, recommendation is that daily tube mobilization, like pushing the tube inward and rotating it, will reduce the risk of BBS. And the loose position of the external bumper at least 1 to 2 centimeters from the abdominal wall will reduce the risk of buried bumper syndrome. It is a strong recommendation with low quality of evidence. In patients with early dislodgement less than 4 weeks, the tract is not mature, so blind insertion should be avoided. Keep the patient NDM, start broad spectrum antibiotic, and wait for healing and do a new PEG procedure. Where the dislodgement is more than after 4 weeks, the tract is mature. In that case, you can insert a balloon type of replacement tube immediately. Use Foley's catheter as a temporary bridge to keep the tract patent. Confirm position endoscopically or with contrast. So overall important points in the summary, use PEG tube feeds for enteral nutrition if the requirement is more than 4 weeks. NGT for temporary support. Gastric route is primary, jejunal for intolerance or aspiration. Always use prophylactic antibiotics for percutaneous tubes. Start enteral nutrition within 3 to 4 hours after uncomplicated PEG placement. Prevent buried bumper syndrome with daily inward mobilization and loose bumpers. These are the summary. Coming to the ASGE in 2025 published a document in which they have proposed 4 recommendations. First recommendation is that we should prefer putting a PEG tube, endoscopic PEG tube, rather than IR guided procedure in patients with normal gut anatomy. It is a conditional recommendation with a low quality of evidence. And the patients who are on dual antiplatelets need not stop the antiplatelets for all the patients. It should be based on patient-to-patient approach. Multidisciplinary discussion should be there because of the risk of bleeding versus cardiovascular events should be discussed in those patients. It is a conditional recommendation. And the patient, we can start feeding within 4 hours. This guidelines also suggest we can start feeding early because it will reduce the hospital stay, and delayed feeding will not improve the survival of the patient. So early feeding is recommended. And in these guidelines, for the patients with head and neck cancer, they're suggesting pull technique or direct peg technique because there is not much increased risk in the pull technique for tumor seeding. It can happen anyway with hematogenous spread. Very minimal risk of tumor seeding with the pull technique. So we can go ahead with the pull peg if there is no expertise to do direct peg in the institution. It is a conditional recommendation with a very low quality of evidence. Thank you. So these are the 2 guidelines I want to discuss regarding the peg tubes.
Yeah, thank you, Chaitanya. Regarding the time of feeding, Chaitanya.
Yes, sir. Yes, sir.
You think it's too early? I mean, now they're studying after 3 hours, we can start the feed.
Yes, sir. Yes, sir. So one reason is that for tract maturation, it will take not more weeks, sir, like 3 or 4 weeks it will take for the tract to mature. There is no benefit in delaying the feeding. If the procedure went well, then the hospital say will come down and early feeding we can start patient.
The question is not waiting for tract maturation. The question is after the procedure, the time that you'd like to give for any local complications, any leaks, anything else that's happening. How much time? Is it just 3 to 4 hours or 6 to 12 hours? What is the optimum time that you'd like to wait before you start your regular feeds?
In the earlier guidance, it was 12 to 24 hours.
Yeah.
Yes, sir. Yes, sir. 12 to 24 hours. Now they are recommending 3 to 4 hours to wait, sir. If there is no complication during the procedure like bleeding or leak you are suspecting, then you can wait. If you think everything went well, patient is stable, then you can start feeding it, sir. 3 to 4 hours later.
I think the clinical judgment is there. The procedure went smoothly and everything is no local tenderness, no subcutaneous, eczema, anything else happening, and everything is clear or tender. You can just go ahead with 3 to 4 hours.
Yes, sir.
With clear fluids initially.
Yes, sir. Yes, sir.
Any other questions from other participants?
I just want to take opinion. Anybody has used a push type peg tube till now?
No.
I don't think they marketed much in India. I've seen them when my was used abroad, but I don't think they really marketed in India.
Yes. Okay. Any other comments? I think we can close, sir.
Yeah, a bit of history of peg tube. The first tube that I placed was actually a Foley's catheter. With this system was devised by Mohandas at TM Tata Memorial as the first indigenous, locally assembled peg tubes, and peg tubes are so expensive. It's very fascinating. You take a Foley's catheter, you cut the stem, you stitch it to the tip as a crossbar. And then you have a 16-gauge Venflon, which you use as the puncture so that you can remove that. And then there's actually, I used a fishing line that I picked up when I'd gone abroad as the pulling thing. So how to pull it, how to push it. So those were, those were the early days when you did not have access to these kits, or the kits were so expensive. So I just wanted to recollect that. That's all.
Yeah, we have one question from the participant. How to prevent peg tube related infections?
Peg tube related
infections.
You have to keep the site very clean. Daily, you have to explain the patient to clean the site, peg site, and all those things. So the local hygiene is very, very important. You should explain.
And prophylactic antibiotics, sir, half an hour before the procedure.
Yeah, that's one time.
One time. So suppose if he has patient is having absolute dysphagia, you are not able to pass your pediatric scope, not able to pass the wire, then it will be difficult. Then what are the choice? How do you go for a peg? Is it a surgical? Is it a ultrasound guided peg?
IR guided.
IR
guided, I think.
IR guided?
Yeah, IR guided.
Anybody is doing?
Yeah, IR people do, sir. First, they will actually take some help of NG feed tubes. They will insufflate the stomach and then they will use the tackers to fix the stomach to the anterior abdominal wall, and then they use the push type of peg tube. And then they will confirm with the
Suppose if the wire
contrast.
is not going at all, so actually I have not. What about NG tube? Yesterday we have a case yesterday, not pediatrics tube, not no rails tube, nothing is going.
Maybe
Then I
surgical.
think surgical is better.
Surgical is okay. Anyway, I am asking for a IR related procedure. Because I read about it, but I came to know that nobody is doing, because everybody is taking that you have to fill the stomach.
Yeah, still I think percutaneous puncture of stomach, insufflate some, distend the stomach, and then some kind of those kind of things.
But I told my surgical colleague to do it under local. He said, okay.
We have one more question from Dr. Krishna. How to prevent leak from peg sites? Chaitanya or anybody can take?
Leak from peg sites.
Yeah.
I think one important thing is we should not, as Dr. Chaitanya has mentioned, accurate positioning of the bumper is very important, because if it is too tight, it can cause buried bumper. If it is too loose, or if it is being manipulated too, violently or roughly, it can cause leaks. It can widen the puncture site and the tract site also. So appropriate care is very important. Sometimes, we have seen bad leaks. Sometimes what happens is, if you kind of apply some kind of the Surgi-Seal, sometimes it can give some kind of temporary relief, or and next time when you replace it, you can use a wider peg tube.
Which tube you are preferring, like Fracab or Cook peg? Which one? Which tube you are most of the, because for all my neurological patient I use Fracab, because even though they pull it out, it won't come. There is a wheel. So Cook peg tube is very soft. They pull it off, it will come out.
Yeah.
So better always use Fracab peg tube for all the neurological patients who are not in good sensorium, because even they pull it out, it won't come out.
No, the problem is Fracab tubes sometimes are not available.
It's very readily available.
They will now again. In last 6 months I couldn't get again.
I have been using only Fracab peg tube after coming from AMC, after coming here.
So the problem with very firm, this one is exchange, sir.
Exchange is difficult.
This Cook one is very easy to exchange.
No, even for Fracab also
you need not even do like full endoscopy. You can.
No, but the problem is they will pull out easily. All neurological, if they pull it will come out very easily. The peg tube.
Yeah, there is a plus, there is a minus. But for us, it will be easier, sir, to exchange.
Cook one lasts longer, for years.
Even Fracab too.
Sir, I have a question. What is the bleeding risk, sir? In the guidelines, they suggest we can continue both aspirin and propylate, and no need to stop anticoagulants because the bleeding risk is not that high, where the cardiovascular disease risk is more. How many of you have done with both antiplatelets and anticoagulants on PEG? After that, you proceeded with PEG test. Any bleeding risk with that?
Yeah.
I think we can do with one antiplatelet, that is aspirin, 75 at least.
Aspirin we can do,
dual
but dual
antiplatelets,
antiplatelet risk
it's
is high.
Difficult, yeah. Even 150 aspirin also sometimes increases the risk.
So we have to discuss with the cardiologist and rationalize the risk and explain to the patient and proceed. Yeah.
Each time, yes.
Yeah.
And even using fluoroscopy assistance along with routine endoscopic PEG direction, sir. Like although it is not necessary, FPEG.
Narendra, for exchange, we use, I think, I use fluoro.
For exchange, yes.
Not for the first time.
For confirmation, anyway, we do an endoscopy and see just how is the placement.
For exchange, without endoscopy, just under fluoro, I use fluoro, but you can do exchange even without fluoro also.
We in Ramya have done a study on 275 patients over 3 years, sir. Like where we had done predominantly in the cases of VP shunts in the first insertion itself. And theoretically, we had shown reduced bleeding risk in those cases. Predominantly along the edges, gastric epiploic artery branches will be more. That's a theoretical explanation which we have.
So you mean to say fluoroscopy reduces the bleeding risk?
To certain extent, sir.
You won't see the, I mean, vasculature, isn't it?
Vasculature, not necessarily, sir, but predominantly identification of the central part rather than the edges. After giving the insufflation, aerogastria, and delineation with some mild contrast, we can see the edges properly. So this case was published in the same publication also.
In which journal?
I'll share it in the group, sir. Like
Sure.
it is in the endoscopic journal. 275 cases we had published.
Okay. I think we had good discussion. Chalpati?
Sir. Yes, sir.
Yeah.
Yes.
Can we conclude the meeting?
Yes, sir. Yes, sir. We can
I think,
conclude. So,
yeah.
thank
First of
everybody.
all, yeah.
Yes, sir. Please.
I would like to thank Dr. Suprasad sir. He has just left. He had some work. Thanks for being there for us. This is the second edition. We'll have the third edition in the next coming 2 months. And thank all the participants, Dr. Kiran, and then Dr. Arun and Dr. Chaitanya. Next time we'll be having one presentation from the Nellore Medical College. Dr. Srinivas sir will be informing us. And hopefully, I think we'll have a good session even in the next session. Now we have Sridhar Bhai also with us. Welcome, sir.
Welcome.
I think we had a good discussion. Huh?
Very useful. Nice one.
So I think I just hand over to Chalpati to conclude.
Yeah, thank you everybody for the active participation. I think this time we had some 53 logins. We'll get the final number. And then thank you, Sun Pharma, for the unconditional support. Thank you, everybody.
Thank you.
Yeah.
Thank you.
Thank you.
Thank you.
Bye-bye.